want to just introduce myself. I'm Misty Rushing. I'm one of the co-leaders for the Dallas-Fort Worth Scleroderma Support Group. And I'm also a board member of the Texas Bluebonnet chapter. So I'm happy to introduce my physician. She's my functional medicine doctor. I've been following functional medicine practices for a few years now, and it's really helped me in reversing a lot of my scleroderma symptoms. And I'm happy to introduce her. Dr. Leanne Sylhan, pardon me, is an MD, and she went to medical school here at UT Southwestern, and then she did a residency at the University of Maryland in Baltimore, and then she was on staff there for about 5 years. She was a part of the faculty at Johns Hopkins University Medical Center for about 5 years, and then came back to UT Southwestern for 2.5 years. And in September of 2019, she opened her functional medicine practice, private practice. And did I leave anything out?
No, that's perfect.
And now, since I've been working with her as a patient, I was introduced to her at a pulmonary fibrosis support group here in Dallas, where I heard her speak, and asked her if she would come and talk to us, because what she had presented that day and my own personal experience I felt would really be beneficial to other members of our community. And so without further ado, I want to introduce Dr. Leanne Sylvan.
Thank you, Misty. Thank you so much. I appreciate you inviting me to talk, and thank you, Diane, for having me, and I'm glad to see such a great turnout. So hopefully I'll get to meet some of you after the conference individually. So just to get started, a few disclosures. So I will be talking about some I'll be talking about some non-approved therapies for scleroderma, some of which are conventional, some of which are more naturopathic. So even a lot of you may be aware that even drugs like Cellcept or mycophenolate are not approved by the FDA for the treatment of scleroderma, although they're very common treatments. Okay, good. And I am a functional integrative medicine specialist and a pulmonologist. So just that disclosure is because I'm not a rheumatologist, so I don't know everything there is to know about scleroderma. I'm sure that there's many of you in here that know more than I do about scleroderma, but I have been treating it since I finished my fellowship in 2013. I was on faculty at Johns Hopkins for about 5 years, doing mostly interstitial lung disease, which involved taking care of a lot of patients with scleroderma. And then doing a similar practice at UT Southwestern, and I just felt that there was more to medicine than checking pulmonary function tests and prescribing a lot of Cellcept, which is what I did for a long time. And it is a very good medication, and I still prescribe it to a lot of people. But I started to become interested in functional medicine a couple years ago, maybe about 3.5 years ago, when I was still in practice at Johns Hopkins, just thinking that there was a lot more outside of the conventional medicine box that I had been trained in, and some of my rheumatology specialists at the time were actually integrating that into some of their practices at the Lupus Center and the Scleroderma Center at Johns Hopkins. So I learned a lot from them, and then I had my own medical issues that kind of solidified that I really needed to look more into this, because I had seen about 9 physicians within 1 year, and the person that said, I think this might be the problem, was the functional medicine doctor that I saw, and she really helped me on a road to recovery with some of my own health issues. So that being said, I have no financial relationships to disclose. So I'm sure all of you in this room are well aware of what scleroderma is, or what we also call systemic sclerosis. This is one of the more common definitions if you look in the textbooks: a chronic disease of unknown cause characterized by hardening and contraction of the skin and connective tissue disease, either locally, which is just in the skin, called morphea or linear scleroderma, or throughout the body, called systemic sclerosis. And as you can see here on this diagram, it can affect the lungs. So that's how I first became involved in caring for people with scleroderma. It can cause both interstitial lung disease and pulmonary hypertension. We'll talk quite a bit more about that a little bit later. uncommonly, but I've seen it a number of times. It can affect the heart muscle itself. It can affect the kidneys, and the leading cause of death in people with scleroderma for many years was actually scleroderma renal crisis, and because of some medications that have been discovered since the 1980s, that's no longer the case. Now it's more lung complications that are problematic. Skin, your musculoskeletal system, the GI tract, both the upper and the lower GI tract, and then you can get some Sjogren's-like symptoms like dry eyes, dry mouth, involvement as well. I love this quote from a great thinker of our times, Jacob Bronowski, and ask an impertinent question and you're on your way to a pertinent answer. So I think in my practice since I finished my fellowship in 2013, I think I've been asked, well, why did I develop this? Probably 1,000 times. And in conventional medicine, we say we don't know. We don't know why people get pulmonary fibrosis. We don't know why people get scleroderma. It's an unknown cause, but this is the diagnosis, and this is how we're going to treat it. And that's what conventional medicine does. Is I love the term. They like to say this at the functional medicine conferences. We name it, blame it, treat it, street it, and that's kind of what you're trained to do. Is you give a diagnosis, and you like define that diagnosis, kind of see what organ systems are affected, and then you treat each organ system accordingly. And that works really well for acute care medicine. It doesn't work quite as well for chronic care medicine. And so that why question that all patients ask, that's what I ask when I've had problems, is why did I develop this, is the tip of the iceberg of kind of getting to what functional medicine is and what it does. So for those of you who are new to what functional medicine is, I first wanted to just talk about, what is it? How is it different than conventional medicine? How is it the same? And I kind of like to think about it if you take all types of medicine that are practiced in the West. So we have conventional medicine, which is what I was trained as a medical doctor of medicine, all the way to like acupuncturists and naturopathic doctors. Is that the functional medicine world kind of bridges that gap. So as a functional medicine doctor, I'm not afraid to prescribe Cellcept, and I'm also not afraid to say that you need to drink berberine tea. So that's more naturopathy. So there's kind of, you get the best of both worlds. So if we think about conventional medicine as being more like disease-oriented, like you label the disease, functional medicine is more health-oriented, and so it does lend itself a lot to like preventative medicine or primary care. And it's a little bit more, it's more holistic, looking at underlying cause, and looking at a lot of biochemistry. So when I was in 2002 as a first-year medical student, I really struggled with biochemistry. It was really hard and very like abstract. Like it wasn't like anatomy where you could like see it and name it and know all the body parts and everything. That part was easy, but the abstractness of biochemistry was difficult. And I was like, what I'm going to do, I'm probably never going to use this again. But actually the biochemical pathways are extremely integrative in functional medicine, and now I love them. And it takes more of a preventative approach. So this is another analogy of like, functional medicine is kind of looking at the iceberg as a whole, as opposed to maybe conventional medicine looking at what the symptoms and the diagnosis are and treating that. And root causes is kind of, if you read about what functional medicine is, you'll see a lot of talk about looking for the root cause. And for any kind of chronic medical condition, it can be from immune imbalances, structural imbalances, inflammatory imbalances, hormonal problems, toxins, digestive problems, mitochondrial dysfunction. And because scleroderma affects so many parts of the body, really, if you take a lot of these root causes of chronic diseases are all incorporated into scleroderma. Some people may have more problems with like a toxic chemical exposure or silica dust that they were exposed to 10 years ago or 20 years ago. Or more people may have problems with a really bad and disturbed microbiome and increased intestinal permeability, also known as leaky gut. So everyone's a little bit different, but these are kind of the root causes of what manifests as scleroderma. And you could say that about a lot of conditions, rheumatoid arthritis, lupus. They're thinking now that Alzheimer's is actually more of like type 3 diabetes. So there's a lot of overlay with a lot of different chronic conditions. There's a whole lot to talk about, and when you hear you have 2 hours to speak, you're like, oh my gosh, there's so many things I could cover. But then you start putting it together, and you're like, wow, there's a lot of things I don't have time to cover. So the first, other than talking about what functional medicine is and why we might consider it, I just wanted to talk about the foundations of functional medicine and how that is applicable to someone who has been afflicted with scleroderma. And then we'll get into some of the more nitty-gritty of like treatment approaches. I wanted to put this together kind of as what does it mean to be well? What does it mean for anyone to be well, either with or without a chronic condition? There's a lot of pieces to wellness. It's not just about what we eat or do we exercise. We think of those things as like, oh, my doctor told me I need to lose weight, or my doctor told me I need to exercise more. But there's a really big integral spiritual part of well-being. And then we often forget one of the other key things of the basic fundamentals of what it takes to live is we have to eat, we have to sleep, and we have to move in some way or another to live. Sleep is a really big part of that integral wellness. So this is more for anyone who's kind of in medicine or interested really in the nitty-gritty of functional medicine. So this is called the functional medicine matrix. And when we are trained to see a patient in functional medicine, we're trained to kind of think about a lot of different things at once and put things on a timeline. And there's some other like paperwork that they say to fill out to help you like kind of process through someone's like history. But you'll notice here on the bottom that these are, this is the foundation. This is the foundation of health. So sleep and relaxation, exercise, movement, nutrition, stress, relationships. And you can put relationships kind of also like a spiritual well-being. So those are the kind of the fundamentals of health. And that is for anyone who either is or is not living with a chronic condition. Because there's no mystery to any of us in here. We're all not going to live forever. And for people I see that just come to me because they want to be healthier, and they're not coming to me for any particular problem. These are, we still go through all of these same things with someone who's not presenting with a chronic condition. Touching a little bit on spiritual well-being and a positive attitude, there's been some really interesting research done in this. So I picked up this book maybe, 4 months ago or so, because this woman right here, Elizabeth Blackburn, who's the first author, she won the Nobel Prize for her discovery of telomerase and the telomeres, which are the DNA at the end of chromosomes that protect them from damage. And damage to your telomeres can cause accelerated diseases such as pulmonary fibrosis. And I've done a lot of research in telomeres, and then they came out with this book, and I was like, oh, that's amazing. Like there's things that can be done in your life to make your telomeres longer, which short telomeres are a huge problem for some people with idiopathic pulmonary fibrosis. So I was like wanting to incorporate that into a protocol that I'm working on for IPF or idiopathic pulmonary fibrosis. So I picked this up, and I was very surprised after going halfway through it. I'm like, wow, this is like really not what I was expecting. So she talks. They do talk a lot about like, how much do you need to sleep and how much should you exercise and how should you eat. But a good like 60% of the book is talking about positive attitude and how our outlook and how our relationships and how our support system actually plays a huge role in how long our telomeres are and how healthy and how much longevity we have. So I was very surprised, because that's not why I picked up the book, and I wasn't expecting it. I'm not a big I'm trying to incorporate meditation and that sort of thing into my life, but I'm not really big on it. But I was like, oh, I should be more supporting this, because it makes a huge difference. And they've done some really amazing research that backs up all their explanations as to why it's so important. And they go through a lot of exercises about how It seems that most of us are either born a pessimist or an optimist. Like that's sort of like my take on people's personalities is like, okay, well, you're kind of born as a pessimist, and that's kind of what you're going to be dealing with. But looking at, there's actually workshops throughout the book that talk about, yeah, you may have been born a pessimist, but this is how you can change your outlook to actually make you more resilient with dealing with stressors that come along in life, whether it be physical or health stressors versus other things. So it's a really interesting, easy read if y'all are interested. And then it doesn't have to be, not everyone wants to meditate on the beach or has access to do that on a regular basis. But spirituality, prayer, and those sort of things have the same positive effects on people's well-being. So sleep. So I think it's funny when people say you want to sleep like a baby. I'm like, well, not like my baby, because my baby wakes up like every 3 hours and has since she was born, and she's 2.5 now. But how do you, what does sleep look like, and what type of good sleep do we need? So we should, in general, most people need somewhere between 7 and 9 hours per night. Ideally, unless I know there's some people in the audience that may be shift workers, but ideally everyone should be asleep between 11 p.m. and 3 a.m. Obviously, that's not enough time, but either that needs to be extended on the front end or the back end. But because of our circadian rhythm and the way that circadian rhythm affects our immune system, 11 p.m. to 3 a.m. is ideal. I've met many people in my life who are night owls and love to be up till 2 a.m. And study after study has shown that is bad for your health. And none of those people that I'm referring to are healthy. So, and then you want to avoid technology before bed. If you can't, some people really like to use the tablets to read with, and blue light blocking glasses can be helpful for up to 2 hours before you go to bed. Movement during the day, and then sunlight. So sunlight regulates your circadian rhythm. If you can't sleep, there's a number of things that we do in functional medicine. I start with really low dose melatonin. I've said 0.5 on here, but actually I have a patient who I had to reduce from 0.5 to 0.3, and she's sleeping awesome, whereas she was sleeping like 6 hours out of 12 every night she was in bed before. So that's the first thing I start with, but there's a lot of people that don't respond to just simply melatonin and need other things. When you look for melatonin at the drugstore, you have to be really careful because it comes frequently up to 10 milligrams, and you never want to start that high. I use high dose melatonin for some people, but more for anti-inflammatory effects, and for people that are resistant to low dose. But you always want to start really low because you don't need much to regulate circadian rhythm. We'll talk a little bit more about CBD through a little bit later in the talk. Tryptophan can be helpful. 5-HTP, which is a precursor to serotonin, can be helpful for a lot of people. Bicalin, which is an herb, I'll talk a little bit more about as well. And then cognitive behavior therapy or biofeedback is actually a really effective way for people that have I have one patient who has really bad insomnia. She's had it for 20 years, and we've tried almost everything that you can take by mouth to try to get her to get better sleep. And she's now doing CBT, and she's had the best response so far. Some people incorporate hypnotherapy into that as well, but just straight cognitive behavior therapy or biofeedback can be really helpful. Particularly with scleroderma, restless leg syndrome, and obstructive sleep apnea are quite common. When we're in our pulmonary fellowship and we get taught about obstructive sleep apnea, we get taught about the short fat man who falls asleep sitting in his lounge chair, and that's what our picture of obstructive sleep apnea is, which is very hindering to making a diagnosis, because it's actually extremely common in scleroderma and in pulmonary fibrosis, which are two patient groups I take care of, and rarely are those people very overweight because of GI absorption issues and whatnot. So OSA is something not to overlook. Restless leg syndrome is very common, and restless leg syndrome is often associated with subclinical iron deficiency. So you may not be iron deficient, or you may not be anemic, but if you do your iron labs, you're often deficient in ferritin, which is the iron storage, the form of iron storage. And the easiest, or the most basic way to treat restless leg syndrome is with iron therapy before you go on, what are the, like, Mirapex and Primoprexol and those sort of drugs. And then definitely for scleroderma-specific issues, raising the head of the bed, either getting, some people use hospital-type beds, some people prefer to sleep on a wedge, and it doesn't have to be a very big wedge. Like this guy has just I think this is like a 4 to 6 inch wedge. That's all you need. Some people prefer to raise the head of the bed like this, but it's really important to prevent any reflux, either acid or non-acid reflux, from damaging the lungs. I'll stop for a second for a breath, and if there's any questions, I can take those now. So a lot of material to get through, but all right. So what about exercise? So when I first put together this talk, I think it was before I did another functional medicine module of education for myself, which I'm going through this several-year process of finishing my certification for it. But I initially put this slide together, and then I went to a conference 2 weeks ago, and then I changed this slide because it had said one of the most anti-inflammatory signals your body can receive. And after I went to the conference, I was like, oh no, it's pretty clear. It is the most anti-inflammatory signal that your body can receive because it does a whole lot of things all at one time. Toll-like receptor 4 is actually one of the targets for low-dose naltrexone that I'll talk a little bit more about, and some of you may be familiar with LDN. So exercise by itself decreases expression of toll-like receptor 4 naturally, which is to inhibit that receptor is very anti-inflammatory. The next bullet point, which is interleukin 1, 6, CRP, and TNF-alpha, those are all pro-inflammatory cytokines, and there's drugs out there on the market that hit every one of those, most of which cost over $10,000 per dose, like rituximab, infliximab, Humira, that target tocilizumab is one of the newer ones that inhibits IL-6. So there's drugs on the market that inhibit those pathways completely. And there's problems with, obviously, these drugs have risks. That's why when you see on TV, ask your doctor about Humira. It could cause nausea, vomiting, death, blah, 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 blah. It's because when you completely inhibit one of these cytokines, there's problems because we need some level of inflammation in our body. And so there's some risk with that. There is little to no risk with exercise other than, if you run on the street, you get hit by a car, or you get too much like benzene exposure from a car. And then there's obviously limits to exercise because of scleroderma, many which are pulmonary, others which are muscular or cardiac or other. I don't prescribe the same type of exercise for any one individual because it is very individual dependent. So Th1 and Th2 are both play a role in suppressing Th17, which is a big problem in people with scleroderma. Exercise improves insulin sensitivity. Insulin, you've probably heard a lot in the last 10 years about insulin resistance and hyperinsulin secretion, which is kind of like the pre-diabetes state. That is a very inflammatory state. So having high insulin levels is not good. And of course, you improve your lipid and cholesterol panel as well. So this is an interesting paper that came out last year about life expectancy in the U.S. In 2019, and looking at people that were completely sedentary versus moderate to highly active, and they actually measured their telomeres, which is very interesting. And this is the current life expectancy in the United States right now. If you're a woman, your average life expectancy is 81. If you're a man, it's 76. And 2 years ago was the first year that life expectancy actually started to go down. So for many, many years, our life expectancy was going up, and now it plateaued, and now it's going back down, which is because of all the chronic medical conditions that are in the U.S. And we can talk more about what that means, and obviously the vast majority is cardiovascular disease and diabetes, but what they found in the study between sedentary individuals and moderately to highly active individuals is that the telomere lengths were 9 years, were equivalent to 9 years longer in the moderate to highly active individuals than they were in the sedentary individuals. So telomeres, which is as I mentioned really briefly, it's these little caps on the end of your chromosomes that protect them from damage over time. Those shorten over time. In everyone, your telomeres get shorter as you age. There's some ways, as that book will go into, to lengthen your telomeres, but aerobic exercise by itself was shown to be 9 years protective. So very interesting kind of paper. They did the study really well. So both of these women are 73 years old. The choice is yours to make. So that's Ernestine Shepard. She's now 81, and she's the oldest competitive bodybuilder who's alive today. And right below her is Arnold, forget his last name, Arnold somebody. He's 82. He's beating her by 1 year, and he's the oldest male bodybuilder competing today. And you can see both of them look, 20 years younger at least, if not younger than that. So how, or when and how? As I said, that my exercise prescription is different for every person. Right now I have the opportunity to be the primary care doctor of my mother-in-law, who has been completely sedentary her entire life and unfortunately got a terrible diagnosis this year, and her oncologist said, you have to move, or like the divergence of like people that are sedentary with her condition and the people that are not sedentary is huge. It's like years of difference from their prognosis. So she's like, you have to move, and we all heard that and we all knew that, and then she let me be her primary care doctor, and the only way I can get her to move is to prescribe physical therapy for her, because someone will come and make her move. And that's her exercise prescription, as opposed to some of my extremely motivated patients who go to yoga 3 times a week and walk on the treadmill and go outside, and so exercise is different for everyone, and I say do what you enjoy and do it often. Morning exercise, planning out your exercise or your day. Morning exercise is typically more successful, not because it's necessarily better to exercise during the morning, just that if you plan it that way, it often gets done, as opposed to putting it off till the end of the day where you're like, okay, now I'm too tired, I don't want to do that. You do want to avoid exercise within 2 hours of bedtime, because the catecholamine stimulation that you get with exercise can keep you awake when you're trying to fall asleep. And from a general standpoint, cardiovascular exercise should be about 150 minutes a week. So if you break that down, if you want to exercise 5 days a week, that's 30 minutes a day of 5 days a week. And that doesn't have to be, I go to the gym for 30 minutes and I walk on the treadmill for 30 minutes. It can be, I went on a 15-minute walk, and then later in the day I did another 15-minute walk, or I did 10 minutes here and 10 minutes here, or whatever. But if you're someone that really likes high-intensity training, that can actually be reduced from a time standpoint. High-intensity training is where you get your heart rate up for short periods of time, and then you do a lighter exercise, and you can consolidate that and make it more like 100 minutes a week. But that's kind of the aim, combined with strength, flexibility, and balance training. My goal at some point someday is to have a class dedicated to patients with scleroderma that does yoga. Because of the skin limitations of what scleroderma does, it makes it very difficult to do some of the flexibility training that's asked for you in yoga, but it's actually very beneficial to keeping your joints mobile over time. And then for anyone with lung involvement, either with interstitial lung disease or pulmonary hypertension, supplemental oxygen is recommended to keep your oxygen at 90% or higher during exercise, and that's whatever that dose is of oxygen that's needed. That's what's recommended. I have had many people ask me well, when I exercise, my oxygen level goes down, so I have to stop. I'm like, okay, well, you have a knob on your oxygen machine, just turn it up and keep going. If you're otherwise okay, you can adjust your oxygen as needed to keep your oxygen saturations up. And then this is actually something I was looking into for my patients with IPF or idiopathic pulmonary fibrosis, but it actually applies to anyone with a chronic lung condition. It's called Ultimate Pulmonary Wellness. Noah Greenspan he's a doctor of physiology. That's him. He's covered in tattoos. He's like the most decorated person you could meet, and his personality is that as well. But he runs this Ultimate Pulmonary Wellness, and he does it in a really interesting way. So you actually, so a lot of times your doctor may prescribe pulmonary rehabilitation, which is like physical therapy for someone with lung disease, but that means you have to go to a facility. That facility may be an hour away from your house. You have to go there several times a week. You have to keep going for weeks on end. And that doesn't work for everyone. Pulmonary rehab's great if it's like down the street and you can do it easily and your insurance is covering it and all that, but it doesn't work for everyone. So this Ultimate Pulmonary Wellness is it's kind of like a Weight Watchers for people with lung problems. Like it's a whole group of people that do these exercises together. It's very regimented. You're going to do this day, and you're going to do this day, and Dr. Greenspan's going to coach you individually, at least once a week, and he puts together a really awesome program that you can do completely online if you want. So nutrition, which is a really big question. I get asked this probably at least, I'm not going to say if it's once a day maybe. I was going to say once a week, but probably once a day, about what should I be eating. So I'm going to go through a couple of cases just for fun, and then talk about what is the right diet for scleroderma. So the first case is a 33-year-old man who is previously healthy. He didn't smoke. He was 185 pounds, 11% body fat, and he walked about 3 miles a day. His diet changed abruptly when he began to eat fast food every single day for a month. After 30 days, he complains of massive headaches, mood swings, feeling depressed, exhausted, poor libido, and has food cravings. And a little bit of data about him. So he gained, in that 1 month, so in 30 days, he gained almost a pound a day, so gained 24 pounds. His body fat went from 11% to 18%. He had fatty liver, and within 1 month, his blood pressure increased from pre-hypertension to stage 1 hypertension, and his cholesterol went up by almost 50 points. Does anyone know who this is? Yeah, it's from Super Size Me, exactly. Spurlock, is it Adam Spurlock? I think his name is. So that was like a great film. If you haven't seen it, it's like 15 years old at this point, but it's worth going back and watching because his wife partners with him. I think she helps him film this, but he basically has to eat every meal at McDonald's for 30 days in a row. And if they ask him if he wants to supersize it, he has to say yes. So if they, the supersize was when they used to go from a big drink to an enormous drink, and the fries that were whatever size it would go to an enormous size of fries. So he has to say yes, and so. This is what happens to him, and it takes him actually almost a year to recover from this. Morgan Spurlock, that's what it was, not Adam. This is just like a picture of what happened to him within 30 days. He didn't quite get to the national average of where the anthropometrics of America is, and then at the end of this, so this was him on day 1, and this is him on day 30. At the end of this, McDonald's actually took off selling some of their supersized stuff because it got such big press. So that's one extreme of a diet. This is one other case. This is a 45-year-old woman who'd had Raynaud's for a long time, family history of both rheumatoid arthritis and ILD, and she'd been diagnosed with limited scleroderma and interstitial lung disease. And she'd been treated for about 6 months and had with Celsep or mycophenolate, which you guys may be familiar with, and her lung function had been stable. She asked her doctor about nutritional changes to help her health, alter her disease course, and she started a specialized diet, all taken on by herself. I was minimally involved in this, other than saying, yeah, there's some dietary things that I think could be helpful. And her PFTs went to FVC of 2.8 to 3, DLCO 60 to 69% respectively, and her joint pain had completely resolved. So what diet did this woman go on? It certainly wasn't the McDonald's Super Size Me diet. I'll tell you that. You guys may be familiar with Dr. Brooke Goldner, who has a really amazing story of her own and very inspiring story of her own about how she became ill with lupus when she was a teenager, and had been told that she needed a kidney transplant at the age of 16 or 17 because she had stage 4 kidney failure from her lupus. And she gets put on all types of chemotherapy, including Cytoxan and several other rounds of medications, and they kind of stabilize out her kidney function. And she's very inspired, and she goes to medical school, and she ends up becoming a psychiatrist of all things. And it was either in medical school or in her residency, she meets her future husband, who's this amazing health trainer and coach, and he's he does a lot of his own health promotion kind of stuff, and he puts her on this special diet to lose weight because she was pretty overweight at the time. I think it must have been in medical school, to lose weight for the wedding. So she's like, I'm going to get in shape for the wedding. I want to lose a little weight, and she goes on a completely vegan, animal protein-free diet, and she's on it for several months in preparation for the wedding. She's losing weight. And she's notices oh, all my aches and pains are gone. I've never felt better than this in my entire life. So she kind of stumbles upon this dietary thing that her future husband put together for her, and realizes what a huge health difference it had made for her. If you're interested in her story, she talks about the whole thing on this. It's like a video or a audio recorded kind of podcast. She talks about her story. So she first wrote Goodbye Lupus, that was a national bestseller, and talks about her dietary plan and how she did it and what she recommends. And then she subsequently then wrote Goodbye Autoimmune Disease, which just came out in the late summer of this last year of 2019. It's a hardcore diet for sure. The first 6 weeks are completely raw, vegan. You drink a lot of these green shakes, but some people do really well on it. And I'm not saying that everyone needs to go on that diet by any means. So what is the right food for scleroderma? So I don't know. If I knew for sure, then I would totally tell you guys. But there's not been a dietary study done for scleroderma patients, period. The closest anyone's come to looking at the diet and how it affects autoimmunity is Brooke Goldner, and her largest paper out right now is 3 patients. So looking at people with actual lupus nephritis who had near kidney failure. I've read it. It's really interesting because it follows each patient through the dietary program, and when some of them had some setbacks in regards to sticking to the program and how their disease correlated with that. So it's pretty interesting. She has it posted on her website now, or a link to it on her website. But I think particularly if you look through the lens of functional medicine, the right diet is specific to an individual. Oftentimes my practice is that I may recommend that someone consider having food sensitivity testing done. There is some evidence for celiac scleroderma overlap in up to 10% of people with scleroderma, and celiac is a very inflammatory disease of the small bowel, untreated celiac is very bad by itself if you take out scleroderma. So I almost always suggest that people at least have a screening test at some point in their period for celiac, if they are wanting to continue to have gluten in their diet, that we rule that out as for sure. And then we tailor what is recommended in regards to dietary changes based on some of these results. Sometimes we'll have people do a comprehensive stool analysis as well and see what type of metabolites are showing up from a microbiome standpoint, and how either healthy or unhealthy the microbiome is. And make changes based on that. All the diets I recommend are high in plants, vegetables, fruit, fiber, and low in inflammatory foods like sugar, processed food, white flour. Sometimes I recommend a gluten-free, dairy-free diet. Sometimes we say that people shouldn't have nightshades. Nightshades are a type of vegetable or fruit in a certain family that can exacerbate autoimmune disease for some people, but it's not the case for everyone. And there is a lot of controversy out there, particularly in functional medicine. It's interesting to hear everybody talk about the lectin debate, so to say. So lectin is a type of protein that's in legumes, beans of all sorts, and some other vegetables. So there's some debate about lectins, and I think probably what's going to turn out for the nightshades and for the lectins is that there's probably people that are sensitive to both, or are sensitive to either or and both of them. But there's probably a large subset of people that can have all the lectins and the nightshades they want, and they're going to be fine. So again, it's got to be tailored very specifically to the person. The gold standard right now is considered an elimination diet, which takes out all the major inflammatory foods for a minimum of 3 weeks, and then reintroduces them kind of one at a time to see if what could or may be a problem for people. That's kind of the gold standard in finding food problems. Although I find food sensitivity testing really helpful, and that's looking at your allergist can't or won't, or they don't do food sensitivity testing. They sometimes will do allergy testing, which is looking at something different. That's looking at an immediate allergy or like anaphylactic sort of reaction to certain foods. They can either do that through skin prick, or sometimes they'll do it through blood work. But food sensitivity testing is looking at IgG blood work, and it hasn't completely caught on in the conventional world yet. Although there are I've seen some rheumatologists starting to offer it and that sort of thing. Unfortunately, you can't find out if you have nightshade or lectin intolerance from food sensitivity testing, because these intolerances are intolerances to the chemical in the plant, it's not an immunologic response to the nightshades or lectins for the most part. Although, of course, you could have a food sensitivity or you could have like a sensitivity to lentils, for example, which have lectins in them, but it's a little bit different. So it's a little bit confusing, but food sensitivity testing can be helpful in trying to sort out that sort of thing. So the Institute of Functional Medicine can be really helpful. They have a couple of what they call diets, which I don't love to use that word because some people get triggered if they've had issues with eating disorders, or they've had yo-yo diet type of thing. So I don't love to use the term diets, but the diets are meant to be short term, like they're somewhere between 3 weeks to as far as like 3 months. And then there's these food plans, which are more meant to be long-term food plans for people. And these food plans include, this one's like the most straightforward, which is just the core food plan, which is basically how, as people, we should probably eat, which is like a lot of plant-based stuff and some protein mixed in, and things that come in packages we probably shouldn't be eating a lot of. This is actually, the phytonutrients is pretty fun because they break all of your healthy fruits and vegetables, or all of your fruits and vegetables, into a color pattern. And my oldest especially, loves to we have this on our fridge, and she loves to be like, okay, well, I checked off the red today, and I checked off this, and generally we should get something from every color every day, so a green, a white, a yellow, or orange, to kind of fill those phytonutrients, which have been shown in several. You guys may be really familiar with some of the autoimmune kind of diets out there right now. There's the Walls protocol, which was written by Dr. Terry Walls, who herself suffered with multiple sclerosis. And there's Brooke Goldner, there's Amy Myers, there's the Hashimoto protocol, and all of those there's one thing that's very, very similar, is that they all say plants are medicine, basically. I was trained in conventional medicine, where I think I got an hour or two of nutrition in my entire medical school training, and I was when my patients would ask me, 5 years ago, what should I be eating? I'm like, oh, well, a good balanced diet, food pyramid, that's what you should eat. But until my own issues with health, did not realize the healing powers of plants, and they really are quite amazing. And then from a protein standpoint, there's a lot of debate in the cardiovascular literature about animal-based protein versus plant-based protein, but certainly for some people, animal-based protein can be very inflammatory. That's been shown pretty well by Dr. Goldner. So I'll stop there for a minute. Each of these other bullets are not quite as extensive and long. Any questions on the fundamentals of functional medicine?
Do you want to address thyroid issues and autoimmunity? Because I thought I was doing myself a favor eating all kinds of raw broccoli and cauliflower and kale, and then I got cysts and nodules and.
Were you having a high?
I didn't know about gomatotropins. I had no idea what they were. I just thought, you eat a lot of raw vegetables and you're good and healthy, but not necessarily with autoimmune issues with thyroid.
Yeah,
you don't need to be cooking all those, and I just bring that up because I didn't know that until I had neck pain and found out I had nodules and things.
So thyroid disease is the most common autoimmune disease in the U.S. We hear about Hashimoto's being the most common and Graves being the second most common of the autoimmune issues. And the biggest risk factor for any type of autoimmune disease is that you already have one. And so many people have thyroiditis or an autoimmune thyroid disease that have other autoimmune conditions like scleroderma. The diet can exacerbate that for sure. So the protein structure in anything you eat that's raw is completely changed when you cook it. Like a very simple example is my daughter, if I give her scrambled eggs, which does not denature the protein because it doesn't cook them enough, her whole face swells up and she starts you're rubbing her eyes and you have to give her epinephrine. But if she eats something baked, then she's fine, because it completely changes the egg structure. Broccoli is the same way. If you steam it at a certain temperature for a certain amount of time, the protein is completely changed from what it was in its raw state. And then the other thing with thyroiditis is you have to be really careful with iodine. Our salt has been, our table salt has been, I don't know what you call it, enriched with iodine since like the 19-teens because of issues with goiters for a public health standpoint. But it really, if you get a lot of iodine in your diet because you think you're doing something healthy by eating lots of nuts and legumes and some shellfish, then you can start to have nodules in your thyroid from. So there are definitely consequences. Your situation's a little bit unique. I've never heard someone just doing a lot of raw vegetables and then getting thyroid issues, but certainly there's implications for a lot of taking on any type of major dietary change. And people who take on a completely plant-based dietary change, we have to look out for certain deficiencies like zinc, B12, some of the other B vitamins. There's some implications in changing the diet drastically. So it should be done cautiously and ideally under the care of someone who kind of knows about that diet and knows what to look out for from a risk standpoint. I'll try to stand back up for a little while. All right, great. Thank you for that comment. Root cause of scleroderma. So maybe this is all why you're here. I'm not sure. If it is, we'll get to that point. So why do people develop autoimmune diseases? So there's certainly genetic underpinnings. So one of the let's take silica, inhaled silica, for instance, which is one of the known risk factors for scleroderma. If you take 100 people that are just from the general population and expose them to inhaled silica, there's going to be only a very small subset that gets scleroderma, even though it's a huge risk factor for scleroderma. So that's because of genetics. There's some people you could give them every single risk factor there's known, and they wouldn't get scleroderma because they don't have the genetic underpinnings for that condition. The genetics, unfortunately, are not autoimmune disease specific. So when we're asking about family history of conditions, we're looking for any kind of autoimmunity. So it might be Hashimoto's thyroiditis, or somebody had MS or somebody in the family had, I don't know, some seemingly unrelated autoimmune disease, but it's the autoimmunity that's sort of the genetic underpinning. The interesting thing is, I had to look this up a while back, is that monozygotic twins, so identical twins, the concordance rate for scleroderma is only 5%. So the genetics have to do with why some people develop the condition, but identical twins only develop that condition at 5%. So if you take everyone that has scleroderma who has an identical twin, only 5% of those people will have a sibling that has their twin sibling that has the condition. And so what else do you need other than the genetic risks? And those genetic risks have not been completely, like you can't go get a genetic panel and be like, am I at risk for scleroderma? It hasn't been very ironed out. Same way with idiopathic pulmonary fibrosis, as we know about 36% of the genes that can lead to pulmonary fibrosis, but we don't know the other 64% that do, that also contribute to pulmonary fibrosis. So the other things that kind of, I think, the forward thinkers in medicine are reaching consistency with is that there's other things that come into the genetics, including gut dysbiosis is a huge one. Thank you very much. Thanks. And other environmental factors that we'll touch on. So where does autoimmunity come from? Thank you so much, Diane. Sorry, I'm getting over a little cold myself this week. So fewer than 5% of monozygotic twins or identical twins and dizygotic twins are concordant for systemic sclerosis or scleroderma. So that's basically what I already said. But they did find in this interesting paper that was just published about 15 years ago now, was that if they did skin biopsies of patients and their genetically identical but unaffected twin, that they had a similar gene expression pattern which can be induced in normal fibroblasts by sera from both. So meaning that their fibroblasts had the same markers on them, the same genetic markers that kind of make them more fibrotic or more prone to scar. But even that, still the concordance rate was only 5%. So there's something going on with the environment or with something in the body that's making some people develop a condition and others not. So Alicia Fasano, is anyone in here familiar with his work? He gives some podcasts and stuff, and if you're interested in gut health, like he's the man for sure. I had a really funny story is that I knew him at one point in time. So when I was a resident at University of Maryland, he had a lab there, and he was a pediatric gastroenterologist studying what is the diarrheal condition, not giardia, but cholera. He was studying cholera at the time, and he kind of like, just as many careers go, he kind of stumbled upon celiac as like something that he wanted to learn more about, and his lab became very successful in kind of identifying celiac and actually identifying there's many people with celiac that don't know they have it because they don't have the GI symptoms. So a lot of celiac manifestations are extra gastrointestinal. And then from there, because celiac is a type of autoimmune disease, it's a reaction, it's an immune reaction to eating gluten. From there, he sprung on to like kind of make these amazing discoveries in autoimmunity and leaky gut and gut dysbiosis. And is known more now in his work with autoimmune disease and inflammatory bowel disease like Crohn's disease and ulcerative colitis. And he gives a lot of talks. You can find him on YouTube and about the type of work that he does and what they've discovered. And he's found that he's a huge proponent of probiotics and found that probiotics. He ran a study in people with certain types of autoimmune disease that probiotics like reversed a lot of the symptoms, mostly in ulcerative colitis and inflammatory bowel disease or Crohn's disease. But this is an interesting paper that's written in a way that people that are not in science or medicine can understand leaky gut and autoimmune diseases.
Can you tell me how to spell that? I can't.
Oh, sure. His last name is Fasano, Fasano, and his first name is Alicio, Alecio. SSIO. He was like the Dr. Dreamy when I was a resident. Are we really human after all? So this is a nice pictograph of the cells, the number of cells in our body, and in and on our body. So 30 trillion human cells as opposed to 100 trillion microbial cells. So we actually have more cells in and on our body that are not human than we have human ones. And if you break that down into the genome, is that 1% of our genes in and on our body are actually human. The rest of them are microbes. So we all are, our body is covered in bacteria. Right now, if you swab your skin and you grow it on a plate, you will grow some type of bacteria. And 98% of those bacteria are helpful bacteria. They live in symbiosis with our bodies. Our gut, our colon, our large bowel is full of stocked of bacteria, and 98.9, somewhere, it depends on how healthy you are, somewhere between 90% and 99% of those are very good bacteria that we need to live and be healthy. And so just kind of an interesting perspective to be like, okay, well, maybe this makes sense that like if you have a problem in the gut that could disturb the immune system, because 70% of our immune system resides within our gastrointestinal system. So this is the gut epithelium, or epithelium here, where it's exposed to our digestive, our products of digestion, our nutrients, our food, what we take in. And these are lymphoid follicles that live within the intestinal wall. So if you count all the T lymphocytes in the body, you're going to find some in the thymus. You're going to find some in scattered lymph nodes throughout the body. But you're going to find the vast majority of them, over 70% of them, reside in the gastrointestinal system. So if you take what you know about how many microbes we have that live in and on us, and you take what you know about the immune system, it's not much of a stretch to say, like, oh, well, maybe this has something to do with immune problems of certain kinds. So what is leaky gut? The other thing you'll see it called in the scientific literature is increased intestinal permeability. So we all are exposed to stressors on a regular basis. Those stressors could be antibiotics, food allergens or food sensitivity particles, pathogens that might live within our bowel, like you get a viral flu or whatever. You get other pathogens we look for, like H. pylori, which is a big one we like to rule out with scleroderma. Stress, so cortisol, which is a major stress hormone, really affects the health of the intestinal lining. And then toxins. There's many toxins. I won't go through all those right now. But normally, this is one of our intestinal cells. Normally, these are really close together, and these are called tight junctions here. And these bad things that we're being exposed to should not be able to get through into the bloodstream. But when you have inflammation in the gut and you have breakdown of the tight junctions, you can see here that things can come through and get into the bloodstream. And so when you have food sensitivities, for example, that doesn't mean that the food is what caused your problem. It just means that these big particles, these big antigen particles, are coming through and getting into the bloodstream. Normally, all that you should see from a protein structure in the bloodstream is amino acids, which are the tiny individual particles of protein. But if you're having these, this what we call leaky gut, then you're getting these large proteins through there. So sometimes it's not that food sensitivities necessarily caused your issue. It's just that if you have food sensitivities, the only way to heal the issue is by not exposing yourself to more and more inflammation from the food sensitivity itself. Sometimes you can reintroduce that food later on and you're fine because you've now healed that where you have these tight junctions back into place. There's a lot of things that can disrupt this. One of the key things that I talk to patients about is about zinc, is that one of the proteins that holds these cells together here is called zonulin, and zinc is at the end of both zonulin, and so if you're zinc deficient, by definition, you get leaky gut. So one thing, if you go and talk to your primary care doctor about testing that you want done, you ask them to check your zinc level, and if that's low, you need zinc, because it will by definition give you leaky gut. And there's a lot of things that can contribute, but that's just one little tidbit of information. So how do we test for this? So there's some stool testing. You can actually look for a zonulin antibody through the stool or through the blood. Alicia Fasano actually discovered zonulin as well. There's some blood and urine testing that you can do, and there's obviously food sensitivity testing. The reason I put this on here is that having a food sensitivity doesn't mean you have leaky gut and vice versa. But if you have, I have a patient who has Sjogren's who has, on the panel of like 97 foods we did on her, she was had a moderate to high sensitivity to like 57 things. She has leaky gut. Like I don't need to do any more testing. I know for sure. If you have more than like 15, they say the chances of you having leaky gut is really high, because it's just like the proteins are just getting through, and your immune system is reacting to them. So a lot of information on that slide. So what do we do about it? So I'll stop here actually for a funny story. So I had it was actually my patient with Sjogren's who has like the 57 food sensitivities. She came and saw me one day and she goes, you know what, my doctor said that he didn't believe in leaky gut. And I thought it was really funny because I'm like, okay, well, that's interesting. It's like kind of like saying you don't believe in like B12 deficiency. It's like there's like ample data out there that like this exists, it's real. Whether or not you believe that it's the underpinnings of why she got sick, that's there's argument there, but saying you don't believe in leaky gut is just like it just tells you that doctor may not be educated maybe in some of the more like up-to-date literature there is out there, because I think most rheumatologists accept this now. Most practitioners who deal with a lot of autoimmunity accept that this is a real thing. But where do you start? What do you do if you have leaky gut? So it's complicated, and in functional medicine, the approach is called the 5 R's. But it's just like basically so you can remember, an acronym so you can remember things. But basically, you need to take out the bad things. You need to put in the good things, and you have to repair the damage. And then you need to reinoculate with good bacteria if your microbiome is disturbed. And most people who have leaky gut or are on a SAD diet, the standard American diet, most people have a pretty poor microbiome. I did my own testing a couple years ago, and I was like, wow, that's pretty sad news. Like it's like on a spectrum. I'm like way down here at the bottom corner, and you want to be way up here at the top corner. So a lot of people need their microbiome addressed, but that's sort of done later down the road when you're dealing with leaky gut. So you don't want to take a lot of lactobacillus and it just goes into your bloodstream, because there are reports of people having bacteremia from probiotics. So you have to kind of take a stepwise approach. So remove the bad. So you can do food sensitivity testing. You could do an elimination diet. You could do a stool analysis to see if there's a problem with the microbiome or if there's pathogens. We often discover some potential pathogens in the stool testing that we do. Yeast overgrowth or candida overgrowth is a problem for a lot of people. And you want to take out the bad stuff like the Twinkies and that sort of thing they're eating from a package that has a lot of chemicals in it that are actually toxins to the bowel. So replace with the good. I'm not going to go through all of that now just for sake of time, but some people need help with digestion. And micronutrient testing is really helpful. Like zinc is one of the things that you can look for and if it's low, you really need zinc to be able to heal the leaky gut. Repair the damage. So there's a protocol we go through. It can include bone broth, or we can do L-glutamine with zinc and vitamin A to help the tight junctions heal, and then reinoculate. And when you reinoculate with prebiotics, you need a lot of fiber, or when probiotics, you need a lot of fiber, what's also called prebiotics. So other things to consider. So we talked about gut dysbiosis in Hawaii. That's a problem. So environmental factors. So silica is one of the big ones. One of the other ones I didn't put on here, which I thought about this on my drive here. I was like, I meant to put that on that slide. That is xenoestrogens. So xenoestrogens are things that mimic that mimic estrogen in our body that are actually toxins. Phthalates is actually one of them. So you may hear a lot on like if you're on the EWG network, environmental working group, about like unclean products. Like I used to love Chanel makeup, and I don't use it anymore because there's like a ton of like chemicals that you shouldn't be putting on your body because they get absorbed into your body. There's a lot of data out there about healthy sunscreens and unhealthy sunscreens now. So toxins is a big one, and chronic infections. So does anyone in here familiar with the Road Back Foundation? It was like really big up until about 15 or 20 years ago, and it's still active. I actually participate with some of their education seminars, and mycoplasma was something that was really, really big. So a physician named Thomas Brown, I think his last name was, he discovered the mycoplasma bacteria within the cells of a fibroblast in a patient with scleroderma, and it kind of made him start changing the way he was treating patients. And a lot of people got better. In the book called, oh my gosh, I'm blanking on the name of it, Scleroderma, Is There a Cure, or something like that. There's a lot of really interesting stories about people that got significantly better by doing antibiotic protocols, and that's because a lot of them probably had chronic infections. We see, I've seen a number of patients who had Lyme disease first and then developed scleroderma, or an autoimmune disease. EBV is a big issue for a lot of chronic illnesses. These chronic infections create weakness within the Th1 system. So Th1 is cytotoxic T cells, which are the T cells in our body that are there to kill things like viruses, bacteria. They don't kill the parasites, and they don't kill protozoal infections. That's done by a different cell. But Th1 is really important in most of the things that we're exposed to on a day-to-day basis. And these chronic infections knock down Th1, where you're not able to kill stuff anymore, and then your kind of chronic viral loads go up and whatnot. And Th2 dominance, they kind of seesaw. So I'll often do a questionnaire in my clinic to see what Th1 and Th2 balance is happening. And then Th1 is also very important with T regulatory cells in dampening the Th17 response, which is very pro-inflammatory and is a huge problem with scleroderma. So these are some of the things that we'll test for, depending on what your background and exposure history may have been. So I'm going to transition into more kind of some treatment-based approaches that are more, I think I mentioned that we, in functional medicine, I feel like we kind of bridge that gap between conventional medicine and naturopathy. So some of this I'm going to talk about here is a little bit more naturopathy and natural ways to address some of the issues with scleroderma. And yes, Diane?
Can I ask a question about something on the previous slide? You were talking about silica dust. That was a problem. I've noticed in a lot of some of the nutrient food products that I've used, like in smoothies and things, they'll have silica gel. And I know they use that to keep it from clumping. I think I've even seen it in like cocoa sometimes.
Right.
Is that similar to the silica dust?
Not that we know of. So yeah, I did a little research on this recently because there's also a lot of personal care products. So makeups or soaps or like all types of stuff you can buy. Even like, you can order stuff from that are EWG approved, and they still have dimethyl silicone in them, I think. And those silicones have been found in labs to be non-antigenic. Doesn't absorb them and doesn't react to them. That's what's published. Now, how much you believe everything you read, I don't know. But yeah, I know what you're talking about. There's silicone in a ton of stuff, and a lot of nutraceuticals and pharmaceuticals will have silicone as a binder in them. As far as I know, and that I've seen in the literature, it's not like inhaling silica dust. which y'all may have heard like recently has been a huge problem for people that are working on the man-made countertops. The silicosis has had this huge rise. I think we're unfortunately going to see a rise in scleroderma because of that as well, because it's the same type of exposure that can lead to silicosis. But good question. The cardiovascular system. So I call it the cardiovascular system because it has to do with blood pressure. But of course, all of our organs are very tightly related, and it's actually really a kidney issue. But as I mentioned at the beginning of the talk, is that up until the 1980s, the largest life-threatening risk in scleroderma was scleroderma renal crisis. And what that is where the scarring around the tiny arterioles within the kidneys make the lumen of the blood vessels so small that blood's not able to pump through effectively, and it causes a severe rise in blood pressure. And there are certain things that can precipitate that, like high-dose steroids, that can be a problem. But in 1981, enalapril was, I can't remember if it was captopril was approved first in 1981. And you can see here that this little white line here is cause of mortality from scleroderma renal crisis starts to go down. And now this is not even now, but this is closer to now. Now we actually see very few complications from scleroderma renal crisis. I've seen it twice in my life where someone had scleroderma renal crisis, and it was not life-threatening, and we addressed it before they ever developed kidney failure from it. One was in a case of a patient who had, I forget why he got steroids, but he got steroids for some reason, and he was in the hospital and developed scleroderma renal crisis in the hospital. But the reason that this has happened, why scleroderma renal crisis used to take almost half of people's lives in the 70s to now less than 10%, is because of these medications that were discovered that very effectively address scleroderma renal crisis. These are called ACE inhibitors, and the standard of care now for anyone suspected of having scleroderma renal crisis is lisinopril, although there's subsequently the angiotensin receptor blockers have come out, ARBs have come out, and sometimes we'll use those instead, and they seem to be just as effective, although they don't have the label for scleroderma renal crisis on them. But unfortunately, what you see is that instead of people having complications with scleroderma renal crisis, is that you see this line here, which goes to here, which is the pulmonary fibrosis, and it's a little bit hard to make out on this graph because it's not colored, but the pulmonary fibrosis complications have gone way up. And it's not, if you read the literature carefully, it's not because people get more pulmonary fibrosis from scleroderma now, it's because people are surviving longer because they're not dying from scleroderma renal crisis, because it's like there's effective treatments for that now. We know to avoid steroids and that sort of thing. And then the other line that's gone up significantly is the pulmonary arterial hypertension. This article is actually from a paper about pulmonary hypertension. So pulmonary hypertension has gone up significantly as well. So we don't want to forget, though, about this thing that used to really be a life-threatening complication, and we want to make sure that we address it. And I had a patient like 2 or 3 weeks ago who came into my office and said, I've been feeling really bad, I've been short of breath, I've just been feeling terrible, and my blood pressure has really been rising. It's been the highest it's ever been. And I called my rheumatologist, and she said I should go to the ER. I was like, what? And so I checked her blood pressure, and I saw her trends, and I was like, oh my God, like, you're developing scleroderma renal crisis. Like, this is going to turn into scleroderma renal crisis. You're like, and she has the RNA polymerase 3 antibody, so she's like, we know that she's high risk. But it still happens. People still develop this condition. You need to recognize it. But what it is basically there's some damage to the kidneys. It's not always caught on like a creatinine. But the blood pressures start to rise. So anyone in here who has a diagnosis of scleroderma, your doctor may have said, check your blood pressure from time to time, particularly if they're positive for the RNA polymerase 3, and there is a risk with the SCL70 antibody too. Check your blood pressure from time to time. Keep an eye on it, and then people start to get protein in their urine, and it is life-threatening. Fortunately, it responds wonderfully to the ACE inhibitors or ARBs, If you use high dose steroids, that's a big risk factor, or if you have certain antibodies. And it's interesting because of what's been learned over time and with these invention of these medications, is that the kidneys actually can recover from this. So they used to, like, people would develop this condition and be like, either they would, have a catastrophic event and die, or they would get a kidney transplant. But it's out now recommended that people wait up to 2 years because the kidneys actually can recover from this if you're on an ACE inhibitor or an ARB. So just something to know about and be familiar with. I think I already covered that. So what about prevention? It is not recommended standard of care that anyone with scleroderma go on to an ACE inhibitor or an ARB for prevention. That is not the recommendation. But are there things that we can do to protect our kidneys? Beetroot juice is actually really interesting. You may have seen them at the health food store, like beet powder. You can get beet powder now. So beets have a huge amount of nitrates in them, there is particularly timely for me now. There's also a study done in pregnant women at risk for preeclampsia who were given 2 ounces of beetroot juice per day, and it lowered their blood pressure significantly, and less of them went on to develop preeclampsia as a complication of pregnancy. But for people with tendencies for high blood pressure, is that beetroot juice can be effective in lowering systolic and diastolic blood pressure. So what are the natural antihypertensives out there? So these all of these foods / supplements have ACE inhibitor efficacy within the body. So zinc happens to be on here, which is, I did not know that until this was a slide taken from one of the IFM conferences. And then we'll talk a little bit more about pycnogenol, because it actually has been recently found to have efficacy with Raynaud's as well. So these are natural ACE inhibitors. Feel free to take a picture, or I'm going to make these slides available to you guys. And then these are the natural ARBs, or angiotensin receptor blockers. CoQ10, which has been known for a long time to help with lowering blood pressure, actually has ARB properties. Vitamin C, resveratrol, which is one of the compounds that for a long time red wine got a lot of good press because it has a tiny amount of resveratrol in it. Let's see. So with that, we'll transition to talking a little about the lungs, and I'll talk about a lot more naturopathy here. And I'm not suggesting that everyone needs to be on all of these supplements, but there's some really good promise, I think, in a lot of them, and I think that we'll be seeing more and more, for better or worse, more and more pharmaceutical companies take on developing these targets as in the more conventional world, pharmaceutical world, and then they'll multiply the price times 1,000, and they'll be harder to get. But So I'm sure most of you are aware that the 2 pulmonary concerns of scleroderma are interstitial lung disease, which is where the inflammation scar tissue happens within the what they call the interstitium of the lung, which is this fine web of network between the air sacs and the capillaries within the lung. A CT scan can look like this, which this is a representative of something called NSIP, or it can have more scarring and fibrosis, which is called UIP. I'm not going to go into all of that now, but that's the interstitial lung disease. And then the other one is the pulmonary arterial hypertension, which is where the blood vessels within the lungs develop scarring and hardening and thickening within them, and that creates a back pressure in the pulmonary artery, and over time can cause problems with the right ventricle, or the RV of the heart. So those are the 2 big pulmonary concerns, and as we saw in that previous slide, one of the larger concerns for people with scleroderma now, from a life-threatening standpoint, So this is a very complex slide that goes through all the different pathways that lead to interstitial lung disease. So the title of this paper was Cellular Interactions in the Pathogenesis of Interstitial Lung Disease. And this is applicable to scleroderma, to people who have rheumatoid arthritis that develop interstitial lung disease, to people that develop idiopathic pulmonary fibrosis. This is not specific to scleroderma. But these drugs and these pharmaceuticals and nutraceuticals I'm going to put up here have different pathways that they hit within that system. So mycophenolator CellCept, which some of you may be on, is a T cell inhibitor. So it's an antimetabolite and causes your bone marrow to make less T cells in number. And so you can kind of see here where that pathway is. Nintedanib, or OFEV, which was just approved or the papers that are going to lead to, they got it approved, came out in May of 2019. It was a drug previously approved for idiopathic pulmonary fibrosis, now approved for scleroderma-related interstitial lung disease. Affects a couple of pathways through the growth inhibitor. So tyrosine, nintedanib is a triple tyrosine kinase inhibitor, very similar to something called Gleevec, which is a medicine that's been used for many, many years for myelodysplastic syndrome or chronic leukemia. OFEV is the brand name, OFEV, and the generic is nintedanib. So that is FDA approved now for the treatment of scleroderma ILD. And you can use these in combination based on the studies that were done in publication for this. The side effect profile is a certain amount for one and a certain amount for the other. When you use them together, the GI side effects are very high. So that's something to be cautious of, because nintedanib in the first study that got it approved caused diarrhea in 60% of people. CellCept can also cause diarrhea, so about 85% of people experience diarrhea in the study that got the OFEV approved. But it is certainly something that should be considered if you have scleroderma-related ILD or interstitial lung disease that is progressing despite being on medication for it. It's something to consider. Those are the only two. Well, nintedanib is the only FDA-approved drug. CellCept or mycophenolate has been used for so long and been shown in smaller studies to be effective that they'll never do a randomized controlled trial to prove that actually works. So it's not FDA-approved and probably never will be, which makes getting it paid for by insurance is sometimes a challenge. This is where glutathione and NAC, or N-acetylcysteine, and some of you have seen me. Sometimes we choose to try N-acetylcysteine, and more recently I've been also putting people on glutathione as well. DHEA, which we'll talk a little bit more about. Berberine, which is a plant compound, is effective here on these two pathways. Bicalin, which is made from American or Chinese skullcap, which is another plant. Godicola, another plant-based therapy. I'm not going to talk about that one in any length. So we have about 15 minutes. I think I have. Let me just poll you guys real quick to kind of decide what we wanted to discuss over the last 15 minutes. So all those things I just showed you on that previous slide, we can talk about that, which will probably take 15 minutes. Or I can skip ahead a little bit and talk a little bit more about low-dose naltrexone and cannabidiol or CBD.
Can you share what dose, these are things that we can just order over the counter. What would be a dosage range you could recommend?
Sure. Yeah, they're in the slides here. So, DHEA. I really recommend with DHEA that you not just go out and purchase it, that you check your levels, and that you're under someone's supervision with it, because it can elevate your testosterone and estrogen as well, and therefore it can increase your risk of certain estrogen receptor cancers like breast cancer. So I'm cautious with the DHEA, although one of my colleagues at Johns Hopkins she was the director for the lupus center at Johns Hopkins. She put everyone on 100 to 200 milligrams daily of DHEA, which is a huge dose. and she found it to be very steroid sparing, and there's like 12 papers out there about it. And so it is used a lot with lupus. It hasn't been studied so much in scleroderma, but it probably has some implications for any type of fibrotic lung disease. And so I use it quite a bit, but I wouldn't just go out and buy your own, because you really need your levels checked as you're on it. Berberine is a great one. The side effect profile for berberine is awesome. It has a potential role for people with pulmonary hypertension, and the dose for that one is 500 milligrams 2 or 3 times. I put 3 times a day, but 2 or 3 times a day. It's sort of like the curcumin of the future, I think. Curcumin or turmeric has gotten a lot of good press for the last 10 years or so, but I think berberine's the one that's going to be out there next as like the good for a lot of different things. Bicalin also great to consider for pulmonary hypertension, and the dose for that one is 200 to 425 twice a day. And it's a good natural kind of mellowing agent, so it's helpful for sleep. So before I go on to talk more about low-dose naltrexone and CBD, so just a word to the wise. So would anyone buy antibiotics from the store? Probably not. Although I have purchased penicillin in Mexico for my father-in-law who got a tooth infection, but that looked like that. It looked like that. But nearly when they did it, this was I think published just 2 years ago in 2018. They did a test of several thousand supplements, and nearly 800 of them sold in the U.S. were found to be contaminated with unapproved ingredients, include banned drugs, lead, other things that you don't want to be putting in your mouth. And this was done in California, of course, where they, it's a much more kind of natural-leaning society, I think, out on the West Coast. And there's another study that came out not too long ago about CBD that I sent to my mom, and I was like, make sure you're not buying any of these CBD products because she's on CBD for pain. And you have to be really careful with what you purchase. And unfortunately, for the most part, you get what you pay for. There are some things that I'm fine with people buying at CVS or Walmart or whatever, which is I'm fine if you get zinc or vitamin C or some of the just because they're very inexpensive to make. And but the things that I tell people is I say don't buy anything that's not made in the U.S. or Canada, because Canada does a good job with regulating their supplements. That doesn't make it foolproof, but definitely don't buy stuff from China that's been shown to be contaminated with lead 80% of the time. And then if you're sourcing your supplements on your own, look for one of these 3 seals, which means that they have been tested by a third party. The supplement's been tested by a third party outside of their organization that makes sure that they don't have contaminants in them that they shouldn't have, and also to make sure that they have what they say that they have in them. You can actually purchase your own subscription to consumerlab.com for $35 for 2 years. It's an awesome, fun thing to play on, and I could spend hours on there. But they're kind of like the wire cutter in that they look for not only good supplements, but the most cost effective. So I don't know if any of you guys use Wirecutter to shop, but they always rank stuff that's really, really high that was good and it wasn't super expensive. So consumerlab.com is a really good one for that. And so if you want to look stuff up on there, and then they also, supplement companies can apply for consumerlab.com to get their seal of approval, which means they have to go through some rigorous testing. The other place that I get supplements is FullScript, which is it's a place that your doctor can prescribe your supplements and their prescription supplements. You can find the ones on FullScript on Amazon or whatever, but they charge you twice as much if you buy them from Amazon. So FullScript is a good place to if your doctor prescribes nutraceuticals to get them. So I think everyone wanted to just kind of skip some of that other stuff and talk a little bit more about LDN. Is that right? And CBD? Did I read the room right? Okay, cool. All right. So low-dose naltrexone, which some of you have heard of, I'm sure, and some of you may be on, is very interesting. So the history of naltrexone was that it came out in the 80s as a medication to counter heroin abuse that was pretty large at the time, a large public health issue. At doses, it was used at doses of 50 to 100 milligrams a day. And if someone who was an addict took naltrexone like they're prescribed and they fell off the wagon and used drugs, or it actually was very effective for alcohol as well, then they wouldn't have the same positive reinforcement that they get from the drug of abuse. And so it would reprogram the brain to basically not have that craving for that drug anymore. Very effective for doing that. What it does is it blocks the mu receptor, and you guys have probably heard of naloxone or Narcan, which is now sold for people to use for for overdoses, because now we have a huge opioid problem. But it's very similar. It blocks the mu receptor. But they found that these people that were using this medication for becoming clean from their drug of abuse, that people that had these chronic inflammatory conditions were getting better. Rheumatoid arthritis was getting better. There was a case of multiple sclerosis getting better. People that had like kind of the fibromyalgia aches and pains were getting better. And it was later discovered, and a lot of research has been done since then, although not nearly enough because it has not gained wide acceptance yet, that at very low doses that it can be anti-inflammatory. And what it does is this is the naltrexone molecule here, is it temporarily binds to the mu receptor, and the endogenous opioid production increases, and once this comes off, there's more to the target neuron, so there's more endogenous opioid production. And in certain conditions, including scleroderma, very interestingly, is that endogenous opioid production is extremely low for reasons that are not well understood. The second thing that the naltrexone does is it binds the toll-like receptor 4 that I mentioned earlier, which is involved in the inflammatory cytokine pathway. So it improves the inflammatory reaction and increases the production of T regulatory cells, which downregulates Th17, which are the bad guys in scleroderma. So I say all this stuff about scleroderma because that's where I am, but there hasn't been that much work done in scleroderma specifically. It's mostly, the data is really pretty good for fibromyalgia, which you'll probably get FDA approval for soon. It's really good for multiple sclerosis and inflammatory bowel disease. To date, there's only been one study done in scleroderma specifically, and this was a study done in looking at pruritus or itching. So not necessarily, certainly a very annoying symptom, but not necessarily like something that's going to be like, okay, well we're going to get the FDA to now approve LDN for scleroderma, but it's the one that has been done so far, and it was done in done in like 3 or 4 patients, where they started people on a low dose, I think either 1.5 or 2 milligrams, and they up-titrated it, and all of the patients in the study had vast improvement in their pruritus scores or their itching scores. That being said, it's been studied more now in Sjogren's. Actually, Scott Zashin, who's a rheumatologist in Dallas, he actually published a paper recently on LDN for Sjogren's, and he's a good friend of mine. So he shared me his good news. So I've read his papers on that. It's pretty interesting. And lupus, it's been studied for. So some of the cousin diseases to scleroderma, it's been studied for now. And I am not shy about using it for scleroderma at all. I think it has a very good safety profile. And it's not the miracle drug that I wish it were, but I think it can be very helpful for some people. Anyways, that's my 2 bits about LDN. So typically I'll start at 1.5 milligrams a night. That's the first month, and then I'll up titrate to somewhere between 4 to 6 milligrams a night as time goes on.
How would you know whether or not you're going to go to 4, 5, or 6?
It's very dependent on the patient's response. So I always see people back and see how they're doing. So I have one woman who couldn't even tolerate 3 milligrams. Like, she did great at 1.5. She felt awesome. She has scleroderma RA overlap, so she has rheumatoid arthritis as well. And her RA was really well controlled on 1.5, but as soon as she went to 3, within a few days, she started having more aches and pains for reasons that I can't explain. So we just dropped her back to 1.5, and we're going to leave her there for a while. So it's very dependent. And then I've had some people that are a little bit resistant. Like, I'm like, well, it's not helping as much as I would like. Let's push it up and see if we can get some more benefit. So it's the art of medicine, unfortunately. Yeah, there's no parameters to measure or anything. You could measure, I guess, CRP and SED rate and that sort of thing, but no correlation that I've ever seen in the literature to say that that's helpful. Yeah. So we're almost done. So I'm glad I'm reaching the end of my slide set. So cannabidiol, which has been really on the rage recently, called CBD or CBD oil. So why is it big now? What is the endocannabinoid system? Because really what we're trying to do with CBD is tap into the endocannabinoid system, which is a natural system in our body. And why have we ignored it for so long? So I just want to say that's me on the left that was 10 years ago. So I was finishing my chief resident year, and we had to give each of us, these are my co-chief residents, we had to give a grand rounds talk to like the entire hospital. So it was incredibly, stress producing, but I decided that I wanted to talk about medicinal marijuana, much to the grievance of some of my mentors, but that's what I wanted to talk about. So it has been around for some time. It's just taken a while to like gain roots in acceptance. And a lot of the history I reviewed at that time, I did not know until I did that talk. But big tobacco actually had a huge thing to do with why. Medicinal marijuana and CBD used to be used super frequently up until like the 30s and 40s. But big tobacco really like squashed it because tobacco was trying to like sell more products, and we all know how wonderful big tobacco is. So they won, marijuana lost, and we kind of lost medicinal use of the plant for many years, and it became known as the gateway drug, and et cetera, et cetera. Would I let my children smoke marijuana when they get older? Absolutely not, because there are some huge drawbacks to the use of the use of recreational marijuana. Particularly, I don't allow anyone to smoke it in my clinic because I am a pulmonologist. But it certainly is helpful for some people with end-stage diseases. Even if they smoke it, I'm like, well, you have a terminal cancer and you have like 3 weeks, so yes, you can smoke as much as you want, kind of thing. But it's like, how do you use it? So marijuana is also known as THC. Is not the same as cannabidiol. So cannabidiol does not have any recreational use. No one would go out and buy a whole bottle of CBD and then let's go party. Like, it doesn't work that way. That would not be a change in your party as if you use nothing. So CBD is in the human endocannabinoid system, but it is actually predominantly affects the CB2 receptor, which does not alter the sensorium in any way of the brain. And we have cannabinoid receptors throughout our entire body, including in our lungs, our brain, our nervous system, obviously. And the endocannabinoid system, because our body makes cannabinoids, has an integral role in sleep, appetite, pain, inflammation, mood, reproduction, and we have endocannabinoids, means that our body makes those, and then we have exogenous cannabinoids like CBD or THC that we can use to augment that system in one way or the other. The data so far for scleroderma is pretty limited, but these are the two papers that have been shown that really was like very promising that cannabidiol was probably very helpful. This particular medication or drug right here, VCE 004.8, is actually in phase 3 clinical trials now. If you're interested and want to know like how can you get into one of those clinical trials, it is active on clinicaltrials.gov, and you can look up like who the primary investigator is, how you get in touch with the research coordinator, et cetera. San Diego is running it out of their center, and a few other places. Obviously, the politics makes some of these studies not as applicable to every center in the country, because there's politics that are different in every state with the use of any type of cannabinoid. But this is an interesting paper too that's written in a way that if you guys are interested in reading it, it's published in, let's see what paper. I'm not able to read it right now. It's written by Garcia Gonzalez, so you can look up Garcia Gonzalez is the lead author on it. And I would say that there is some promise that CBD may be really helpful in preventing progression of systemic sclerosis. I don't think that so I didn't talk about CBD yet, or I didn't talk about it in the same way I talked about nutraceuticals. We also have to be very careful with what type of CBD you get. There is a seal of certification that the company that makes the CBD or markets the CBD can apply to get if they want to get the seal of approval. And I would only get CBD from one of those companies if it were up to me. They do tend to be more expensive, although there's some tinctures, which are the water-soluble CBDs that you can get on the market, that are running like $30 to $40 a bottle, rather than $100 to $200 a bottle. But it is pretty pricey, and there's a lot of political movement in Texas to have medicinal uses of cannabinoids in general expanded, because right now you can buy CBD if you want CBD oil at the hemp store or whatever, and it's probably like you might get 8 milligrams for the whole bottle, so it's not very regulated, and they can say whatever they want to say about it. Right now it's not covered by insurance, all of those things are bad, and it's really, if you get the good stuff, it's really pricey. But I do think it probably has some role in chronic autoimmune diseases, and the mechanisms of action are very promising in regards to how that will work. This particular drug right here, the VCE 004.8, that is not just CBD oil. It's like a minute compound that reacts on one receptor on the CBD2 receptor. That's it's a chemical compound. It's manufactured. It's not. They didn't get it from the plant. Like, this medicine is not made from the plant itself. So Big Pharma is trying to use some of these molecular mechanisms to find drugs that work that they can then market for profit. So for better or worse. Yes.
For the patients that want more information on that, at our national conference last year, there was an hour-long talk on it. A lot of detail about what medications will minimize the effects of CBD, what medications will accelerate the effects of CBD. So you can go out to the YouTube channel for the Scleroderma Foundation and look for the name CBD, and you can watch that whole session. So it will expand upon what Dr. Silhan.
Yeah, great, Diane. That's awesome. I need to watch that myself, because I didn't hear that talk. All right. Well, I think we're going to draw to an end here. So I'm just going to talk a little bit more that you guys can have my slides. Pycnogenol has recently been found to be helpful for Raynaud's. And just a little bit about GERD. Pycnogenol. Oh, really? Awesome. Yeah. Awesome. It helps lower blood pressure too, so be careful if your blood pressure runs really low. GERD. So I won't go into great depth about this, because you guys are all very familiar with reflux and scleroderma, I think. And that's a good time to end, because my slides just disappeared again. But there was one more slide I wanted to show you, just because So you guys all being here shows that you're active and that you want to learn more about what's going on with research out there. But clinicaltrials.gov is a great place to go if you want to be involved in a pharmaceutical clinical trial, or there's other things out there that they do trials on that are recruiting small numbers of patients that I think are always really interesting. Like that's how they did that study on the LDN and scleroderma that was like 3 or 4 patients. It was a very small study. But if someone's doing a clinical trial within a university setting, they have to put it on clinicaltrials.gov. And then sometime over the next year, I hope to be enrolling some people in Photobiomodulation Therapy, which has been shown to be very effective in certain inflammatory conditions, including psoriasis, this is a before and after picture of psoriasis. You can see here on the right bottom. The phototherapy technology has advanced so much now that they can penetrate deep tissues. And so I think there's some promise in that, but it hasn't even been begun to be looked at in scleroderma. I've talked to a number of people that are involved in the making of these machines, which are like almost $100,000 for these machines. But they're like, oh, what's these? I'm like, well, can we use it in this disease? They're like, they don't know what that is. They don't know what scleroderma is. So just to speak to Diane's point is that a lot of people haven't even heard of it. So. Anyhow, I'll stop there. Sorry to go over a little bit, but I'll make these slides available so that you can see part of the presentation we didn't get to.